My name is David Coffey. I'm a medical oncologist at the Seattle Cancer Care Alliance, and I specialize in the treatment of multiple myeloma. And I'm thrilled to be here today. I want to thank the myeloma crowd for asking me to participate. Today, I'm going to be moderating the session on high-risk multiple myeloma case studies. And this should be an interactive discussion between the panelists regarding some cases regarding high-risk multiple myeloma. I'm going to be discussing two cases today. The first case will be an example patient with high-risk multiple myeloma, and we will talk about initial treatment for the disease. And in the second case, we'll be talking about a case of a patient with high-risk multiple myeloma whom has relapsed disease. The purpose of this discussion is to illustrate that there is no one-size-fits-all, that we should have some differences in opinion because there is no one perfect sequence of therapy for high-risk multiple myeloma, and a lot of factors need to be considered. And hopefully you will see through our interaction that there is certainly multiple choices one could choose. So on to the first case. This is of a 65-year-old man who presented with severe back pain and fatigue for several months to the emergency department. While in the emergency department, a CT scan was obtained, and it showed diffuse multiple lytic lesions in his bones throughout the spine. This led to a serum protein electrophoresis, and it uncovered a 4 gram per deciliter IgG kappa monoclonal protein. His kidney function was evaluated and was found to be normal, but he was determined to be moderately anemic, likely contributing to why he was so fatigued. So a bone marrow biopsy was obtained, and this demonstrated 90% of the cells in the bone marrow to be plasma cells and of an abnormal type. And FISH studies demonstrated translocation 414 and deletion 17p, which you heard earlier today put him into a high-risk category. So he was given the diagnosis of revised International Staging System 3 multiple myeloma with high-risk cytogenetics. Now for our panelist members, here's the first question. What initial treatment do you recommend for high-risk multiple myeloma?
Okay, well, I can take a first stab.
Yeah.
Okay. So as was mentioned, we don't have prospective randomized data specifically for high risk or ultra high risk telling us what the best triplet or quadruplet is or what the best approach is. I would certainly want to know whether there is any underlying cardiac disease with this individual, just to be able to gauge safety of using carfilzomib with my induction regimen. Again, there's no comparisons for high-risk disease patients for RVD versus KRD. The study that we do have really excluded patients like this one in this case. So even though that study didn't show any benefit for carfilzomib over bortezomib, I would tend to do something more like KRD if there was not any contraindication from a cardiac perspective. Having said that, another option that's emerging these days is DARA RVD as a quadruplet. But again, based on the available data we have from Griffin, there isn't really a huge signal for benefit for the ultra high risk patient population. So I'd have the discussion with my patient about options and side effects, and then recommend consolidation with a transplant.
Yeah, I totally agree. From my perspective, the SWOG study that was just reported tried to add agents to the BRD backbone to show a benefit over BRD for other combinations and did not show. So BRD alone would be reasonable. As long as the patient was responding, you always have, I'm a little bit more of a believer in response adapted treatment. If the patient gets BRD and responds quickly, and then they move on to transplant, and then I would put them on 3-drug maintenance based on this risk. But as Dr. Holstein just said, KRD induction would be reasonable if the patient could tolerate that. Quadruplet induction could be reasonable if they could go that, or join a clinical trial would be reasonable. Right now, there are CAR-T trials that would take a patient with RISS stage 3 and 414, where CAR-T would be given instead of an auto transplant. And the option of auto transplant still exists for this patient because they could just collect and store their cells. So I would try to put him on the trial. Barring that, I would offer the same options that Dr. Holstein did.
Yeah, I agree with Dr. Hari and Dr. Holstein. I think induction with a proteasome inhibitor and IMiD combination would be the minimum here. You know, RVD or KRD. You know, although we have the endurance trial that showed, you know, no apparent improvement in progression-free survival with KRD. Another way to look at it is KRD is not inferior to RVD, and you know, certainly.
Yeah.
I have seen patients, you know, not respond to RVD who are high risk, who KRD is a much more effective regimen. So either would be fine. I think the question of adding DARA to RVD for high risk patients is unanswered, at least based on the minimal data that we have. And I think, you know, the paradigm of more is always better may not always apply. Certainly for post-transplant maintenance, the 3-drug combination would be something I would recommend. And I think it would be reasonable to consider a tandem transplant. That's something a tandem autologous transplant. That's something we've been discussing at our center. But I also like the idea that Dr. Hari mentioned of the study that we are going to open as well here of BCMA CAR T cells after induction for high-risk patients. And so I would definitely consider that study for this patient.
Thank you for that excellent discussion. Hopefully the audience members were able to appreciate that there are a variety of options, and it wasn't clear that there is one best option, and that's because there isn't. And in this particular case, the patient went on to receive bortezomib, lenalidomide, dexamethasone, also known as the VRD combination. It's probably our most common combination that we give for initially diagnosed multiple myeloma, and that does include high risk if we look across trends in the United States. Fortunately, this was a good choice for this patient, as his monoclonal protein had decreased from 4 to 0.4 after just 4 cycles of therapy. The bone marrow biopsy, though, did show some substantial residual disease. The number of plasma cells reduced from 90% to 20%. So my second question for the panelists is, when is the right time to proceed to an autologous stem cell transplant? Should it be after a fixed number of cycles of induction therapy, or should it be based off of an evaluation such as the one he had that showed some residual disease?
This is a great question, David. I think, you know, we have tended, or I have tended to try to treat to maximal response. And so for me, having residual plasmacytosis of 20%, I would probably continue RVD for maybe 2 cycles or so before proceeding. That's not necessarily data driven. Certainly, you know, if you look at like determination trial or IFM 2009, everybody got 3 or 4 cycles of RVD and then went to transplant. And so there's data for that. But perhaps maybe, I guess, intuitively, I've always felt like getting the deepest response is always best before transplant. But that's not, you know, necessarily driven by clinical trial results.
I would agree with that completely. I don't tend to use a fixed number of cycles approach. You know, some information that's missing here is what happened after each cycle. So we started at 4 and went down to 0.4, but after cycle 3 was at 0.5, and now with cycle 4 it just went to 0.4. So is the response plateauing, or has there really been a good decrease with each cycle? So that type of information about the rate of change with each cycle would inform whether I think pushing with a few more cycles of VRD is going to get me to where I want to be. The side effect profile sometimes comes into play as well, because some patients, even with just 4 cycles, really start to have neuropathy issues, which make it difficult to keep pushing with the VRD. Our center tends to have the threshold of 10% plasma cells before giving the okay for stem cell collection, but that's, as was just discussed, not really based on data. So I don't need to I tell patients that I don't expect or need to get them to 0 with everything being perfect, but I generally do want to achieve a very good partial response and less than 10% plasma cells before taking them to stem cell transplant, if possible.
I agree with both of my co-panelists. This patient is actually in a VGPR just by the M spike. although a VGPR also needs 10% plasma cells if you look at the IMWG rules. So patients VGPR by biochemistry, but not quite by the plasma cells. And I would say the majority of, we look at a lot of these transplants coming in through the CIBMTR, the data. Most patients are in PR or VGPR. So only a minority actually are in VGPR getting to a transplant. There are two ways of thinking about it. One is that you could continue the VRD and get a deeper benefit. The other is that the cells that are after 4 cycles of VRD still surviving are going to be best killed by the biggest weapon on hand, which is, the melphalan, the high-dose melphalan, and you might actually just take them to transplant. If in fact, the patient had no response to VRD, in fact, they were resistant and their M spike went from 4 to 3, I would just take them to transplant, perhaps do a tandem transplant, because but if they were serially responding, as Dr. Holstein just mentioned, then there is reason to continue for a little bit more. But the side effect of giving too many cycles of VRD is that the mobilization of stem cells becomes a little bit more difficult. Not impossible, but a little bit more difficult.
That's a wonderful discussion. And I tell you that we have essentially that same discussion all the time within our transplant group at our center. And I think all the opinions expressed today are kind of consistent with how we think at the Seattle Cancer Care Alliance. So in general, to reiterate what was said, the patient has numerous options going forward. He has achieved a very good partial response based off of a decline in his monoclonal protein by 90%, but he still has residual disease in the bone marrow. One option is to give some additional cycles of the same induction therapy he has already had, and then proceed to stem cell mobilization. Another option would be to do something called chemo mobilization. That wasn't discussed today, but it's something that we commonly do. We combine a number of chemotherapy drugs, such as carfilzomib, Revlimid, dexamethasone, and PACE, and give that just prior to mobilizing the stem cells as a little additional boost to try and clean up any residual disease before moving on to stem cell transplant. So these are all very good options, and not one is necessarily the best. And I agree with the point that was made about looking at the rate of change over time. I didn't provide the measurement of the M protein after each cycle, but if indeed it looks like it's reached its nadir after consistent measurements, giving more treatment is probably not going to reduce the M protein any further. So let's talk about what happened next. So he went on to receive an autologous stem cell transplant. And fortunately, his monoclonal protein became undetectable 3 months after the transplant. His bone marrow biopsy also showed 1% plasma cells. So the question is next, what treatment would you recommend after autologous stem cell transplant?
For this patient, I would probably recommend RVD maintenance with a lower dose of dexamethasone and just enough, and then about 10 to 15 milligrams of Revlimid and bortezomib combined with that, either weekly, 3 weeks on, 1 week off, or every other week as extended maintenance for at least 2 to 3 years.
And Dr.
Same
Hari,
answer for me.
after the VRD, would you go on to stop treatment altogether if he stays in a remission, or would you move on to a single drug like Velcade after the VRD is completed?
After the VRD is completed, I'd probably leave him on Revlimid, because that's the one drug that's been associated with a prolonged overall survival, at least 2 to 3 years of additional benefit over Velcade alone. So I would probably complete the VRD and then go on to a Revlimid alone as maintenance if the patient's still progression-free at the end of 2 to 3 years.
I agree with Dr. Hari.
Okay.
I agree as well.
Okay, so it sounds like there's more consensus here to receive Velcade, Revlimid, dexamethasone as maintenance therapy for a couple of years, and then move on to Revlimid maintenance thereafter. Now, he had translocation 414 and deletion 17p. You would recommend Revlimid as opposed to Velcade?
Absolutely. There's actually minimal data showing PFS or OS benefit with single agent bortezomib, but we do have data from the Myeloma 11 study for lenalidomide where they looked at their portion of patients who had FISH testing showing benefit even in patients with ultra high risk disease with single agent lenalidomide.
Great, thank you. So I put together some alternative options he would consider. So after the stem cell transplant, he could consider an allogeneic stem cell transplant. I would do that mostly in a clinical trial. A second autologous transplant was discussed early on as a tandem auto transplant. Consolidation therapy would be my terminology for using a triplet after auto transplant, and maintenance therapy would be my terminology for a single agent. So it sounds like, and this panelist would prefer the route of consolidation with VRD followed by maintenance. Thank you so much. Let's talk about our next case. So this is a 53-year-old woman who presented with swelling in her legs for several months, as well as a complaint of foamy urine. She saw her primary care physician, and her kidney function, called creatinine, was determined to be elevated. It measured 3 milligrams per deciliter. Normal is under 1.2. So a kidney biopsy was obtained, and it showed kappa light chain nephropathy. Serum protein electrophoresis confirmed a 6 gram per deciliter IgG kappa monoclonal protein. A bone marrow biopsy was obtained showing 75% plasma cells, and FISH identified deletion 17p. So like our prior patient, she was diagnosed with revised International Staging System 3 multiple myeloma with high-risk cytogenetics. So she initially was recommended to receive cyclophosphamide, bortezomib, and dexamethasone. She received this as opposed to a lenalidomide type treatment was because of her kidney function. Abnormal kidney function and Revlimid don't generally mix well together, so she was given cyclophosphamide. After a couple of cycles, her creatinine improved dramatically to almost normal levels, and her monoclonal protein also was showing a good response. To deepen that response, and because her kidney function improved, Revlimid was replaced from the Cytoxan, and her creatinine returned to normal after 6 cycles of treatment. Monoclonal protein decreased to 0.5, and her bone marrow showed 5% plasma cells from the 75% before. So an autologous stem cell transplant was recommended for this patient, and 3 months later, her monoclonal protein became undetectable, and her bone marrow showed no abnormal plasma cells. So she was very fortunate to have received a stringent, complete remission. In this case, Velcade was given for her as maintenance therapy. Unfortunately, 1 year after this treatment, a bone marrow biopsy was obtained showing less than 1% plasma cells in her bone marrow, and FISH again showed deletion 17p. Her monoclonal protein rose slightly from 0 to 0.1, and an MRI was obtained showing no focal lesions. So the first question here is, when do you decide to change therapy? And is there enough evidence at this point in time for this patient to change therapy?
So I can go at it again. So this is a 53-year-old lady who's already showing recurrence of disease, at least molecularly or at a low level within a year of transplant on decent maintenance. This is the patient for whom I usually try to offer a customized approach. I would tell this patient that you have high-risk disease by prediction. You are demonstrating that the high-risk disease matters because after a year of transplant, after excellent induction and good response, you're not behaving like somebody who had a stringent complete response after transplant and then stayed on maintenance. So this is bad news. You have multiple options. One is to join a clinical trial right now again. We have clinical trials for early relapse where basically you could get a 3-drug reinduction with Darzalex, pomalidomide, dexamethasone, versus, which would be all 3 new agents for her versus a CAR-T. But unfortunately, she has to wait for clinical relapse, which means her M protein has to go up to 0.5 at least to get that, she has to meet IMWG relapse, which is 0.5, or clinical relapse, which means her kidney function has to go up. So, but she stands to lose a lot by waiting. So this is one patient for whom I would also discuss allo transplant as an option. And hopefully in the next year or so, we would be having patients like these be able to get CAR T cells, etc. So this is a patient for whom everything is on the table from clinical trials, early treatment of this with a standard of care regimen such as Darzalex, Pomdex, or wait a little bit more with very close observation. And as soon as the M protein hits 0.5, put her on a clinical trial.
I think it's important to note that, what changes our thinking here is not just the biochemical relapse. I think if you had a different patient who maybe had RVD induction and standard risk chromosomal changes and, maybe a biochemical relapse, I might not be pressed to change quite yet. But I think the fact that there is a known high risk feature, that it is an early relapse within 1 year, those definitely would make me more concerned. And I definitely would as as Dr. Hari said, put everything on the table. I probably would not sit on this and watch and wait for too long, because these are the patients I have seen where things can change, within, weeks. So yes, I think I would, any of the options that were mentioned would be reasonable. At our center, we will have a study soon of a 4-drug regimen for treating relapse after transplant. And so that would be something I would probably consider for this patient.
I agree. The decision for when to change therapy for early relapse after transplant has to be patient specific. And again, just to reiterate, we knew from the get-go, or we predicted from the get-go, that this patient was going to have a harder time because of the cytogenetic abnormalities. And then, in fact, the relapse is happening quite early. So I would agree this would not be somebody that I would take well, we can just continue the Velcade for a couple more months and see what happens. I would change therapy.
Thank you all for your input. So let's see what happened in this case. So in this case, the patient decided to remain on therapy for 1 more month and recheck labs. And sure enough, the M protein increased from 0.1 to 0.3 after 4 weeks, indicating that this disease is moving quickly. So now that we know that treatment is definitely indicated, and there's no question about that, what factors do you consider in selecting a new treatment for a patient with relapse disease? So specifically, what patient factors might be considered, like prior history of therapy, age, things like that, and what cancer-specific factors might you consider when choosing the next drug? Lots of options were already mentioned, but how do you narrow those down?
I think about where I want to go next. Am I doing something that's a bridge to a major next step, such as another stem cell transplant, although I wouldn't do another auto transplant in this patient, but am I picking a therapy that's a bridge to an allogeneic stem cell transplant, or as a bridge to CAR T in the future? Am I picking a therapy that I want them to be able to stay on long-term, or at least until progression, that they can tolerate and that they can work around if they're still working? The side effect profile is important as well. And then anything we can learn from the disease biology in terms of, what was it that they progressed on? Was it an IMiD? Was it a proteasome inhibitor? What did they get up front? And what comorbidities do they have at this point? Do they have neuropathy, CHF, kidney disease, et cetera? So again, it comes down to really making decisions that are patient specific. And this is why I think having approaches where you just have algorithms where you assume that all patients are equal and you just follow the path is not helpful for individual patients.
Yeah, I agree as well. I think it is a patient-driven decision. I think, for this patient, and many patients, if there's an early relapse or if we're really pressed, we have to push to start therapy. I think as others have echoed, I think a clinical trial, if it's highly promising, would be probably the first thing I would think of. After that, I would, as Dr. Holstein mentioned, look at prior therapies and what has worked well in the past, what they haven't had. But I think a clinical trial would be the first thing I would look at, provided the patient was eligible and what would be a good fit.
Yeah, really nothing more to add. That's exactly what we would recommend too.
I think you've hit on the next question. What about this last question? Dr. Holstein mentioned that a second auto transplant is not something that you would consider for this patient. Can you just briefly comment on why?
I often tell patients if it didn't work the first time, it's unlikely to work the second time unless we're doing something really unique. So are we adding something to melphalan? Are we doing something unique afterwards in terms of, tandem auto CAR T cell therapy? Are we doing something unique from a consolidation maintenance perspective? But if we don't have that from a clinical trial perspective, then I don't see why just giving the melphalan again and expecting different outcomes is actually going to improve things.
Yeah, we generally like to follow the rule that the patient's had a remission that's lasting greater than 18 months after their first transplant. But that's a reasonable, good response, and that we could consider a second transplant. This patient relapsed sooner, just within 1 year. Okay, I know we're about out of time, so I'm going to just give a brief summary here of some of the important points that I want everyone to take home. When you're selecting treatment for newly diagnosed or relapsed multiple myeloma, take into account the fact that treatment responses are going to be variable, even among similar patients. So there is no one size fits all. The optimal sequence of therapy is unknown. And so if one person gets one combination of therapy and has a good response, it doesn't mean that everyone would. Both patient and cancer-specific factors need to be taken into consideration when choosing therapy. And one should always consider a second opinion when the treatment choice is unclear. Always consider a clinical trial for high-risk multiple myeloma, since standard therapy is suboptimal. If you're looking for clinical trials, you can use clinicaltrials.gov website to search for trials for multiple myeloma around the country. Thank you all for your excellent comments.
Okay, thank you, Dr. Coffey, and thank you to our panelists. One other comment that I'd like to make is clinicaltrials.gov has a listing of all the clinical trials. If you're using HealthTree, you can see personally relevant clinical trials that are just specifically those you can personally join. So you may want to consider that, because we're taking like your platelet count or your creatinine level or whatnot, and we're finding all the eligibility criteria and doing the matching for you. So it's a little easier to navigate than clinicaltrials.gov, but you can definitely find them all there.